Hello, my name is Eric Ford, and I'd like to talk to you today about strategic control and corporate governance. This lecture series has 6 parts. In other words, you'll have to watch 6 separate videos. And I'd like to start by talking a little bit about the Center for Medicare and Medicaid Services Triple Aim program. But first, the learning objectives. After watching this lecture, you should have a good understanding of how effective strategic control systems and strategy implementation lead to successful and sustainable business practices. You'll learn the difference between traditional and what I'm going to call contemporary control systems, although this is an evolving field and what's today's contemporary may be something different tomorrow. We'll talk about the imperative, and I'm not sure imperative is the right word, but why we've moved to contemporary control systems. In addition, we'll talk about the benefits of having a good balance among culture, incentives and rewards, and boundaries as means of behavioral control. And by the way, just a little bit of nomenclature here. Rewards mean when we give you something for doing what we hope happens. Incentives is typically a negative term. In other words, that's the stick part. If the rewards are the carrot, the incentives are the stick. So it's a little bit of politeness, but don't be fooled. We'll talk about the 3 key participants in corporate governments, shareholders, management, and typically we're talking about the C-suite here, the executive suite, and the board of directors. There's actually other forms of corporate governance that go on beyond that, including the external control of organizations. We'll talk about that some as well. We'll talk about the role of corporate governance mechanisms to ensure managers are aligned, and we'll go into something called Sarbox, or Sarbanes-Oxley, to a limited extent. So first I'd like to talk about an example, and this is something called the Triple Aim. And this was originally rolled out by an organization called the Institute for Healthcare Improvement. This was founded in Cambridge, Massachusetts. Several of the physicians that had appointments at Harvard, Women's and Children's, Brigham Women and Children, etc., started to work on healthcare systems and improving those. And in the first decade, they had something called the Breakthrough Collaborative Series. And this is where they were working with infection control primarily, and other sorts of errors that occurred in the ED, or emergency department, or ICU, the intensive care unit. And their goal was to eliminate preventable medical errors. In the second decade, they focused on innovation, idealized design of projects, medication systems, including computerized prescription order entry, those sorts of electronic technologies, etc. They moved into something called Pursuing Perfection in 2002, and this was funded by the Robert Wood Johnson Foundation, often called RWJF. And they were working to seek total transformation of healthcare processes across entire systems, not just hospitals or physicians' offices, but a much broader set of goals. Then we had the 100,000 Lives campaign, and this is where the IHI sped best practices throughout hospitals. A lot of this also revolved around the use of lists and some other work by a man named Peter Pronovost at Johns Hopkins and some of those sorts of initiatives. And their goal was to create a national network here in the U.S. for improvements focused on reducing medical needs, deaths, and preventing harm. The IHI is actually an international collaborative. It's engaged in England, Scotland, and as you can see, some sub-Saharan African countries. The English connection is particularly strong, or the UK, because Scotland and England actually have a comparable system. And we see Don Berwick, who's currently the director of the Centers for Medicare and Medicaid Services, who founded IHI, has spent a great deal of his professional experience working in the UK in something called NICE, the National Institute for Comparative Effectiveness, NICE, where they do some of this. This topic gains some notoriety during the last presidential campaign, and Sarah Palin was the vice presidential candidate at the time, and she talked about death panels. Well, the National Institute for Comparative Effectiveness in England, and if we were to form one, and we have in fact here in the United States, would be the proverbial death panel she's referring to, for your information. So what are the triple aim? As I look at my screen, you see the gentleman wearing a tie. That's Don Berwick, and the gentleman on the left is Dr. Nolan. And they started to re-envision healthcare, and they were doing this external to hospitals, but they wanted to talk about the triple aim: population health, the experience of care, and the cost per capita. Now, if you think about this in relationship to some of the other topics we're going to talk about in this lecture, you'll see how this all comes to bear. So what are some examples of measures or strategic controls that the triple aim looks to work on? Well, we talk about functional health status. These are different empirically derived surveys that we use in public health in particular to measure people's functional status. We talk about risk status, or the composite health risk assessment. These are scores, again, that talk about how likely are you to suffer some long-term illness or disability. We also talk about disease burden, incidence and prevalence of disease. Those are sort of classics. And the simplest and perhaps the easiest to understand is mortality. All right. In terms of the patient experience, this is an area that in healthcare we've really ignored, or at least ignored the implications of it as part of our operational strategies for a very long time. We've measured it, but we haven't actually taken those lessons. The U.S. CAHPS, this is actually a study that's run by the Agency for Healthcare Research and Quality, and it measures people's experiences, their patient satisfaction. The NHS, the National Health System in the UK, also does these sort of things. Let's talk about per capita cost. In the United States, we have a per capita cost of healthcare that's about twice that of other industrialized nations, and that's a big problem. And you probably hear that our Medicare system in particular is leading to some of the insolvency concerns in our federal government. And part of that stems from the way we access care through hospitals and emergency departments. So how did the triple aim evolve? Well, they started with initial prototyping in 2007 and 8, and they took in 15 organizations. And again, these were already successful organizations, I should tell you. People like Kaiser, Geisinger, big names in the healthcare field. And they asked, what can you do to accomplish these goals? Well, you had to define your target population, figure out how you could impact them. In other words, what was causing most of their disease burden. And what can you do to accomplish all three aims? And they started to measure this in earnest, okay? And so that was the goal. And it became what they call a learning system, where they were hoping to learn as they did this and change some of the practices in other facilities as they went. So what are the drivers of low value? And why do I call the U.S. healthcare system low value? Well, it's because we have high costs, as I mentioned earlier, nearly double per capita what other industrialized or Western European countries typically spend. And we also have low quality. Now, with respect to quality, I'm not sure that our quality of our care is significantly lower than you find in other countries, but it is certainly more expensive. What is driving some of these costs? Well, you often hear it attributed to technological advance, and there's certainly some of that. The lack of control mechanisms and agency problems. I think if you read your text closely, you'll see there's a fairly long description of agency problems. What kind of agency problems do physicians have? They are both the seller and the purchaser of healthcare services. So you have what's called a supply-driven demand, and that's a very particular agency problem. What about low quality? Well, I mentioned doctors. Essentially, doctors monitor their own quality. If they say they're doing a good job, we accept that they say what they say, and that's problematic. Insignificant role of individuals. In other words, most of us aren't highly involved in our own healthcare decision-making system. And undervaluing system design. The U.S. health system is largely as it was designed in the late 1920s and 30s, with hospitals being a central focus, physicians having largely complete autonomy from the rest of the system, and a sort of archaic billing system. So what are some of the key issues? Well, we talk about the social determinants of health, and this is the community you live in, the culture of health surrounding where you live. Is it viewed as it being important to look healthy and be healthy, etc. We talk about fragmentation of health services. Can your primary care physician talk effectively with your specialists and hospital? And misalignment of incentives. I think what the authors here are largely thinking about is the way we pay for healthcare services. In other words, we pay for offering the services, not the quality of the services received. So we have a misaligned incentive to do the best care possible. As you see, here's how health is determined in our country. We talk about genetic predisposition. That's about a third of what determines your health status. If your parents have alcoholism or are obese, it's likely that you're susceptible to those same maladies. Behavioral patterns. Do you live in a community where walking to work and public transit are the norm? That adds about 1.5 miles or 2 miles a day in many communities to people's exercise regime and can be a difference in life expectancy of several years, believe it or not. We also talk about your social circumstances. This is in the upper right-hand corner of this pie chart, which accounts for about 15%. And one of the lower numbers is actually the quality of your health care. In other words, physicians and other people are only adding about 10% to your life expectancy. And you can see that there. So there's the need for an integrator, or something that brings together all the disparate parts of our healthcare system and puts a strategic control feature around them. And so what do we need to do? Restructure organizations. You often hear about something called accountable care organizations or patient-centered medical homes, and these are supposed to be those integrators. And it pulls together the resources to support a defined population. We shouldn't talk about how your primary care physician treats you. We should talk about how that doctor's population is receiving care. We need to build alliances and coalitions. Again, we're trying to optimize the triple aim. All right? And we also need to redesign the microsystems. The triple aim is really a social movement. In this sense, it's an external control on the organizations it's trying to affect. And we see this more and more in healthcare with organizations like the Leapfrog Group and Bridges to Excellence. So it's not just shareholders, the board of directors, or the supply chain or CEO that's determining organizational controls and what success looks like. We often see these other parties, external mechanisms, implementing strategic controls and trying to steer the market toward better attainment of those goals. And it's dealing with how care is delivered. What is delivered? In other words, we deliver many services that simply aren't needed. One of the most expensive times of life is the end of life. And the estimates around how much we spend on people's end-of-life care for what we gain are really staggering. 20 and 30% of all spending goes into the last 2 weeks of people's life. And is that the best use of that fund? That's a big question we're going to have to come to grips with, and your generation in particular will. And also, who drives change? As I mentioned earlier, physicians really own the entire authority as well as the responsibility for how healthcare is delivered. So the triple aim paradigm, as they want to refer to it, system design, reorganizing, creating value of systems of care, patient engagement. In other words, you have to take responsibility for your own health. And quality of services. It's not just enough that we delivered the services. Did the services do what they were intended? The triple aim is moving forward. The fact that Dr. Berwick is now the director of the Centers for Medicare and Medicaid Services can tell you that he's occupying a position that delivers about a third of all health care in this country. And if anybody is in a position to do it, he is now. We'll see about these ACOs, Accountable Care Organizations, and whether these regional triple aim collaboratives are able to form and create patient-centered medical homes where physicians, hospitals, insurers, and other community members are brought together. So strategic control in the eyes of Dr. Berwick. Well, what do we say when we first see data that we don't like? The data is wrong. Then we come to the grip with the fact the data is right, but it's not our problem, that's somebody else's. Then we say the data are right, but it's a problem, it's just not my problem. And lastly, as a manager or a leader, you need to accept the burden of improvement and take hold of your strategic control and take ownership of it. All right, part 2 of this section is a case study that's available through links on my website.